second part of the seventh quarterly meeting for EHAC. I would like to, welcome Professor Divya Sheshadri, who is the secretary for the EHAC Trust, and he is also the clinical professor of marketing for ISB. And ISB has been very, very kind enough to, help us co-host this session. So I would like to, invite Professor Divya to introduce the panel and, speak a few words. Divya.
So friends, warm welcome on behalf of EHAC for this second panel discussion of today. And the topic cannot be more timely. COVID, as many experts in the field realize, is not a one-off event. We can expect more and more pandemics, and people like Dr. Sailesh Rao, who has been studying climate change and the way that human beings are intruding into the wildlife in a big way, has created huge amount of opportunities for wildlife and humans to come in close contact. So that's a very different topic. However, the conclusion of a lot of research is that by humans' activities on this earth, pandemics will continue to haunt us for a long time unless we make major course corrections that won't happen in a short time. So we are going to discuss basically how does the world in general and India in particular get its act ready for handling future pandemics. That's the broad thrust of this panel discussion, and we can't think of a more erudite and experienced and scholarly group of panelists than the ones that we have who have kindly consented to be part of this panel. It's my pleasure and honor and privilege to introduce the panelists, starting with Dr. GBS Murthy. He is the director of the Indian Institute of Public Health in Hyderabad, and they also have a Bangalore campus. He's got very enviable track record over 35 years, and he has contributed extensively to research, policy formulation, and program implementation in public health, epidemiology, public health eye care, and public health disability. He's also the director of the South Asia Center for Disability, Inclusive Development and Research. He's a professor, public health, eye care, and disability at London School of Hygiene and Tropical Medicine. He developed the first ever Department of Public Health Ophthalmology in India in 1992 at the RP Center for Ophthalmic Sciences at AIIMS, Delhi, the first WHO collaborative center for prevention of blindness in Southeast Asia. So he comes with phenomenal exposure and authority to speak on the subject of how do we gear up as a country to future pandemics. Thank you, sir, for joining us for this panel discussion. Next, we have Dr. Pavitra Mohan, who is at the other end of the country, if I may say, diagonally opposite at Udaipur. And he founded Basic Healthcare Services in 2012, motivated by a labor of love. I visited his area of his work, and it is quite incredible the type of I would say personal sacrifice he and his wife have done to operate in that tribal area of Udaipur district, about 3 hours from Udaipur city. It's a non-profit organization, the one that he founded, to promote models of high quality, low cost primary healthcare in underserved areas. And I think his basic philosophy is how do you go into promotive and preventive healthcare rather than just escalate straight away to secondary or even tertiary. And if you look at the phenomenon that has happened in big cities, even if I have a common cold, I think the days of a family physician are all gone. They have become extinct species. And I have to run to an Apollo or a Fortis. This is the tragedy in a large measure. And that results in choking up of the tertiary care facilities. Arnaz, one step back, please. So he has worked and contributed extensively to the field of newborn and child health, equity in healthcare, and human resources for healthcare in India. His contribution to the field of neonatal health was awarded fellowship by National Neonatology Forum of India. He is also a recipient of the Ashoka Fellowship 2019. He is himself a pediatric doctor, and so is his wife. And together they have done this labor of love called Basic Healthcare Services. He left a very lucrative job in UNICEF, and also he was a professor of medicine at the Rajasthan Udaipur Medical College. With that, we go to Dr. Evita Fernandez, who doesn't need any introduction. She's the chairperson of the 70-year-old Fernandez Hospital. She's a reputed and respected obstetrician with 3 decades of experience. She's a fellow of the Royal College of Obstetricians and Gynecologists, London. She's also the managing trustee of Fernandez Hospital Education and Research Foundation that works with Fernandez Hospital. She strongly believes in empowering the woman delivering babies, and she personally ensures that woman-centric care is provided at all the 5 hospitals that are part of the Fernandez group. And the care is delivered with respect, kindness, and compassion. That women should make their own choices about issues surrounding birth. She is also now spearheading a nationwide campaign to move in line with her philosophy towards more midwifery practice, because she believes a majority of births, like 90% and upwards, can be done by midwives, and we have over-medicalized the birthing process. And Telangana is one of the biggest offenders, with about 70% deliveries happening in Hyderabad through cesareans and so on. So she's rolling out a nationwide program to evangelize the midwifery. And then we have Mr. Anas Wajid, Max Healthcare Institute, and he's an extraordinary person who is running a very, very large hospital chain. He's a senior director and chief sales and marketing officer at Max Healthcare. He's responsible for spearheading all brand marketing and sales activities at Max Healthcare to achieve its vision to become the most admired healthcare company in the country. This is a very, very audacious vision or a goal, because it's a very competitive field for tertiary care. And he's a part of this thing of making Max the most admired healthcare provider. He has more than 17 years of experience in diverse fields, including advertising, retail, healthcare, and media. His previous assignment at Fortis as the chief sales and marketing head for the group, Anas had been instrumental in driving innovative initiatives in the area of marketing communication, domestic and international sales. And the reason we requested Mr. Anas Wajid to be here is he comes from the big hospital perspective, mega hospital healthcare providers. So we have at one end of the spectrum, Dr. Pavitra Mohan, and at the other end of the spectrum, Anas, and in between, Dr. Evita, and overseeing all of this, Dr. Murthy, because he comes from the policy angle. I can't think of a better forum than this to help us to understand how we as a nation should be prepared for the next wave of pandemics. While we hope and pray they don't come, it appears from many thought leaders that these are inevitable. With that, I would like to hand over back to Arnas.
Yeah, I would like to invite Dr. Murthy now to give his presentation.
Thank you, Arnaz and Dr. Seshadri. It is an honor to be here with all of you and share some of my thoughts in relation to what we need to do in looking at the future pandemics. Like Dr. Seshadri mentioned, I think we all have to remember that there is apprehension right over, whether it is the politicians or whether it is the policymakers, the clinicians or the community at large. And therefore, this is a very appropriate moment to talk about what we need to do or what we have failed to do in terms of looking at pandemics. Just to start off with a historical perspective in terms of what we know, because not everything is recorded, but looking at a starting point about 430 BC, when Athens lost its reputation as the Greek at the end, brought about the end of the Greek Golden Age, going on to the plague pandemic in Europe, which killed more than 40% of the population at that time. Moving on to Latin America, where smallpox.
Dr. Murthy, excuse
Yeah.
me, we can't see your PPT. It's not visible on screen. I mean, there is something else showing up.
Let me start again then.
Yeah.
Is it visible now?
Yes, but yeah, I think you need to click and you need to get into slide mode. Yeah. Yes, now it's fine. Thank you.
Right. So I'll just go to this particular cartoon, which is very appropriate for today, because everybody, right from the politician to the civil society, is apprehensive, scared, and anxious as to what is happening in the world today. Like I was just mentioning, if I were to look at a historical perspective, starting off with about 430 BC, moving on to plague in Europe, which killed about 40% of the population in the 1300s, to smallpox in Latin America, to the influenza outbreak of 1918, to which we refer so much now as a sort of a baseline in comparison with where we are today, responsible for about 50 million deaths. And in terms of COVID, we are still counting. But what we need to see is that the frequency with which pandemics affected the human population, it was nearly 1400 to 1500 years, then it moved into about 1000 years, and now we've moved into a situation where we are seeing these pandemics at intervals of less than 100 years. And that is something which is significant, which means that we are in a situation where we have to act soon. We know about a large number of the recent outbreaks, and I'm just looking at beyond 2000. And we've had the SARS, the Zika, cholera in Haiti, in Zimbabwe, Ebola. And a lot of the learning that we have is both from Ebola and the influenza pandemic, which still persists across the globe. And what we have done when we've come to COVID is to try and use the experience of whatever we've gained over the last 20 years in the recent pandemics. So just to take our attention to what we mean when we talk about pandemics and talking about infectious diseases. So they're basically caused by microorganisms or their toxic byproducts and have the potential for rapid spread, affecting huge numbers across a country, a region, or globally. In the last 2 decades, we have seen about 20 well-known infectious diseases which have reoccurred or re-emerged, and 30 new ones in the last 30 years. So we are in a situation where we are faced with a huge number of organisms which are surrounding us right through. The other conflict that we have today is the re-emergence of the drug-resistant variants or the mutated variants, which have also created havoc across humankind. Just to reiterate the fact that a large number of what we are seeing today in terms of infections are zoonotic in nature. That means they have jumped from animals to humans. So 75% of what we see today are animal originated organisms which have broken the chain and affected humans. So it's not a small number. This busy slide shows you that there is a global perspective, and you have either newly emerging, which are the red ones, or the re-emerging, and you see the blue ones here, which are all re-emerging, or deliberately emerging, like we saw with anthrax, and also in terms of stupidity of some individuals or groups who have been against measles vaccination in the US. So the global war is against infectious diseases, whether they are new or re-emerging. Let's step back and see what we mean by these terms that we use so frequently. So pandemics occur when microbes appear for the first time in the human population, for which people have no immunity. And that's when it has a propensity to spread right across. And when peak intensity ends, the diseases are more likely to become more persistent, which we call as endemic, that is constant presence. And many times, like we've seen with the influenza vaccine or the virus, the organisms mutate and continue to remain challenges and push us towards finding new ways of tackling them. So an endemic, an infection which is within a geographic area, but that which exists constantly. An outbreak, which is the sort of an initial spark, is an illness that is much more than what people have anticipated and also shows up in unexpected places. Then you move on to an epidemic, which is a sustained spread in a short period of time to the surrounding geographic areas. And if you then go on across countries, across boundaries, across regions, then you're entering into the pandemic phase. And why this is important is also to try and link it with development. Pandemics produce a tremendous amount of economic loss. And if you look at uh, India, we fall in the top bracket of countries which are adversely affected because of economic loss in pandemics. This is 2008 data, and up to 2% of the GDP is lost in our country because of pandemics. So what is pandemic preparedness, which is what we are referring to today, is the sum total or aggregate of all the measures, policies formulated before the event occurs. It's not after, it is before the event occurs, to try and prevent or reduce the damage that could otherwise have been caused. And in this, we look at two major verticals. One is risk assessment, which is looking at the possibility of occurrence of an outbreak in the future, and risk management, which looks more at the control strategies to look at actions which could modify the probability that a big outbreak would occur. We also need to consider the fact that we need to decrease the vulnerability, which also means increasing the resilience of the populations of the society so that one can face the future outbreaks to alleviate the apprehension around future outbreaks much more effectively. So this is what pandemic preparedness refers to. And the goal for all pandemic preparedness is to look at a sustainable reduction in the risk which leads to these outbreaks. And the objectives increase the awareness of the risk and look at the risk reduction strategies being shared with populations, capacity building at all levels of healthcare in the health system, having appropriate systems in place, procedures in place, and providing resources, including the monetary support, to provide prompt, effective assistance, what we call as the rapid response. The operational readiness to act without any delay, which looks at creating buffer stocks, having your inventories of medicines, vaccines, and all the other equipment that is required to act without delay. We have to remember, like I said, 75% have jumped from the animal to the human kingdom. So if we have to look at preparing ourselves, we must have a good integrated surveillance system, which is called the one-hand surveillance, to start tracking any outbreaks not only in the human population, but at the animal level also. And if you find new organisms, like we see the COVID-19 outbreak, before you can get certain measures in place, there are specific generic control measures which have to be rolled out immediately. What is important for pandemic preparations is evidence generation and dissemination. And this has to be transparent. You can't hide behind iron curtains if you're looking at using evidence to make a difference to breaking the chain of transmission for pandemics. So if you look at this cycle, we start with the situation of formulating policies, and then we look into strategic planning to prevent future occurrence. And this is the what is required, which is the strategic planning. Then we look at how do we operationalize this, the how, as to how we can actually make it happen. How could the strategies be actually operationalized? Once you have that on your plate, we then need to look at piloting it, simulating the situations so that we are prepared to face any outbreak that is bound to occur in the present days. Building inventories, keeping your stocks ready, having your standard operating procedures, protocols, skilling the health workforce and other frontline workers so that everybody is ready to jump in. And that is what we call the response readiness. So this is the cycle which is required if we are looking at preparedness planning. Monitoring is very critical because you may start with a hypothesis, but then you find that there is a change in the way we have been dealing with the situation. So monitoring and the feedback so the policies could be changed appropriately is again very critical. The continuum of the pandemic phases, like the World Health Organization describes, is very critical when we are fighting pandemics. It is the preparedness phase, which is the inter-pandemic phase, which is at both ends of the outbreak, which is very critical. And we need to do a risk assessment right through so that we are ready to act, to respond appropriately, to see that there is a recovery which happens as quickly as possible, and then be prepared for the next generation of outbreaks that may occur. So these two ends, the inter-pandemic phase is the preparedness phase where we have to put our thinking caps on and try and have everything ready. But before the pandemic breaks, you also have an alert phase, and actions taken during the alert phase can actually go a long way in making a difference. And I'll just look at the Indian outbreak graph to give an indication about that. So if you look at the daily new COVID cases in India and you see this chart, you see that it is on the downward limb now, but we perhaps missed a trick or two. Right at the beginning, before the pandemic was declared, which is the pre-pandemic phase, starting from the end of last year till about the beginning of the first quarter of this year was perhaps a pre-pandemic phase. And immediately after that, before the lockdown or the first few weeks of the lockdown was the alert phase. And these two phases are very, very critical if we have to reduce these numbers dramatically. Unfortunately, I think we were all overwhelmed and did not take it in the seriousness that was required to make a difference and reduce the numbers. So these two phases are very critical. They're giving you an early warning that you need to have your game in place right now. So when you're preparing, we're looking at 7 steps. One is the planning. You look at identifying resources, in a position to allocate resources for pandemic control right in the beginning. You have to earmark funds if you have to look at making a difference. And then you need to look at the coordination function. You need a nodal authority. You can't have multiple authorities talking about tackling a pandemic. It has to be one voice, one nodal point, and everybody else supports that nodal point. Unfortunately, this was also missed out in our current state of affairs. responsibilities, what each individual would do, what each department would do, their specific roles and responsibilities is again very, very important. The private sector, we forget that the largest segment of the health sector is in the private sector. And unless they are involved in the planning and are actively participating, we would not get adequate reporting and we would not know where we are in terms of trends. Empowerment, which is again very, very critical. Civil society empowerment is very critical if we are looking at making a difference to future pandemics. It brings in an ownership and prepares them with evidence so that they can also act proactively without waiting for other activities to happen. But one of the important things to keep in mind is the simulation. Unless we are prepared, it's just like, you go to the Murthy driving school, you have your simulators, and then you are in a better position to be a better driver on the roads. And that is only possible when you have been able to simulate and have your drills in place to actively be ready for the response. It has to be multi-sectoral, multidisciplinary, and all stakeholders need to be involved in the planning and control process. Unless that is done, we would not be prepared. Recently, the World Health Organization and the World Bank has set up a group called the Global Preparedness Monitoring Board. This was set up last year, and they also have 7 major recommendations. The most important being that the leadership should be the one that drives progress. So the heads of government must commit and invest money in terms of pandemic control. Also, lead by example. So you have to become like Singapore, like Taiwan, like Vietnam, so that you are acting by example and showing how the countries should actually act. And the different groupings, G7, G20, G77, the UN, all of them have a responsibility here. We then need to look at building effective systems. And unless we have a strong public health system, we would be failing in pandemic after pandemic. I talked about the coordinator and the coordination role, but most important for us is to prepare for the worst, not the least. And I think most of us across the globe have made the mistake of preparing for the least rather than preparing for the worst. And this is again very, very critical. You need to have financial commitments, and financing bodies should link their risk planning to mitigate severe economic losses that could occur because of an outbreak. And development assistance funding, because social development is so critical when you're looking at pandemics, also need to be on the same plane in order to make a difference. And international coordination, so that there is transparency in information, outbreaks being informed immediately so that one can prepare to face them and see that they don't cross the national boundaries. And the UN plays a very important role in terms of this coordination. We also have what has been recently developed as the Epidemic Preparedness Index. And this looks at scoring countries based on 5 major heads. The public health infrastructure, which looks at capacities, the skills, immunizations, surveillance, etc. The physical infrastructure, which is more developmental in nature, looking at all the social determinants, logistics, the communications, the road networks, water, sanitation, etc. The institutional capacity, which is looking at how countries fare in relation to political stability, corruption, etc. The economic resources, which are important in making a difference, and the communication functions. How is information being shared with the community so that they are better prepared to face any challenge that comes up? So this is the Epidemic Preparedness Index. We also have what is called the Operational Readiness Index, which looks at how ready countries are, in what operational phase they are in facing a challenge And countries have been divided into 5 levels. Level 1 is very little functional capacity. Level 2 is little functional capacity, whereas level 5 is well advanced and sustainable health system. So 104 countries were thought to be operationally ready to prevent, detect, and control an epidemic of a novel infectious disease. Despite that, we had havoc being caused because of these lack of seriousness, which is important. So you could be operationally ready, but if the political dispensation does not give it the serious thought that is required, then we would be in a poor position. Looking at India, India falls in level 4, and that means that we are functionally capable at all levels, but despite that, we did not deliver despite having a good operational readiness index. We also need to keep in mind that we need to do whole of society pandemic planning. It cannot be only the health sector or only the education sector. It has to be whole of society. And this is because pandemics have consequences for the entire society. All organizations, public or private, need to plan for potential disruption, including employee absenteeism, as we are seeing in India today. And we need to prepare the economic, humanitarian, and societal consequences. Templates have to be ready for that. There is a significant threat to continuity of essential services and shortage of supplies, which is why a whole of society approach is very, very critical. Businesses are impacted, and perhaps the worst impacted are the travel and the tourism industries. Robust preparedness plans are critical, and the whole of society approach will have a tremendous amount of additional benefit because it strengthens the community willpower to withstand threats. And if you look at what happens, whether it is in terms of the readiness, the response, or the recovery, at all levels of care, subnational, national, local, all of these are affected, whether it's health, defense, law and order, finance, transportation, communications, energy, food, water. So all this put together mean that a pandemic needs a whole of society approach. Advanced preparation is critical because of these reasons. We look at 3 domains here: social, nutrition, and health and rehabilitation, generalized panic, anxiety, apprehension, displacement, gender-based violence, which we've seen a lot in the last 9 months, persons with disability, the human rights and ethical aspects, the educational sector and the employment sector, whether it is educational losses or job losses in the wider world. In the nutritional domain, food distribution, whether it is for antenatal care, midday school programs, shortages, or the food distribution systems getting impacted. But more in terms of the health and rehabilitation, every aspect of the health sector is impacted. There is disruption in routine healthcare, in provision of medical supplies, and also features like rehabilitation and deployment. We see that when it comes to terrorism, we have mock drills, and these are different airports in the country where you have mock drills. But unfortunately, let us ponder, have we ever seriously thought about pandemic preparedness drills? And I think this is critical. That's the way you prepare yourself. There are steps to be taken in the intervening period. You need surveillance that generates information that could be used to plan. And these are the early warning systems. And we need to have notification and reporting, which is real time, not paper-based, which comes 8 months down the line. We also need to invest in modeling, epidemiological modeling, which helps in predicting outbreaks and looking at what is the way it will spread, what could be the intensity, and could also prepare you in terms of what public health interventions are required. And these are most important, the immediate pre-pandemic or the alert phase. We have to see that we should have our assumptions as pragmatic and realistic as possible. And unless we develop in having this sort of an epidemiological modeling, we would always be playing the catch up and would be having a problem. We have one big advantage today, unlike previous pandemics, and that is the digital technology response. And this is right across, whether it's infection prevention and control, identification of hotspots, contact tracing, or remote clinical management. A lot of hospitals have done that recently. Information support and capacity building. So digital technology is an advantage for us in terms of future pandemics, and we have to harness that effectively. Community ownership is critical because it is the community members who know their communities best. They're well versed with the community perceptions and are better peer educators than any of us. We see that the cup and charge, whatever be the negativity around them, they have a span of control which can make a big difference in pandemics. And unless civil society is involved in the planning right from the beginning, it will be a situation where it's a lost game. We've seen that in relation to COVID, where civil society has played an important role, though not the driving role, which is important. Communities also bring in trust, and trust is critical. The recent study in the US shows that community organizations were trusted more than any other source of information on COVID-19, including the federal, state, and other government agencies. And the reasons for that is they could see tangible benefits, things like food provision, social support, virtual religious services, and dissemination of COVID-19 related information. So if trust is critical, then community participation and empowerment is critical for future pandemics. We should not have a situation like this. This is from the Deccan Chronicle a couple of days ago. I really admire Mr. Subhani. You can't play games with people's trust. And that is why serious planning for pandemics is very, very important. Despite all that, there would be certain uncertainties. We don't know sometimes which pathogen it is. What could be the expected level of severity? Are our assumptions correct? Or do we need to modify our assumptions? What about the operational logistical procedures to have things in place and considerations of the ethical and human rights perspectives? So there are uncertainties even in the best planned situation, but having some uncertainties unknown is better than having all uncertainties completely over the place with no understanding at all. So just to end, I'll refer to Dr. Tedros's comment, the WHO Director General, that this will not be the last pandemic. History has taught us and will teach us that outbreaks and pandemics are part of our life, and the world must be better prepared for the next pandemic. We need to invest in public health if we have to make a difference. When the next pandemic comes, the world must be ready, more ready than it was this time. Let's look at our Hyderabad sporting icons, Mr. VVS Lakshman or PV Sindhu. They did not fight their battles or challenges by just going in and unprepared and fighting it out. They prepared to the extent of winning the gold medal or becoming somebody called Mr. Very, very special Lakshman. So preparedness is the key in all aspects of life, whether it's sports or whether it is pandemic control. Thank you for the honor to listen to me. Back to you, Dr. Seshadri.
Thank you, Dr. Murthy.
Thank you, Dr. Murthy, for a fascinating talk. Really, it opened our eyes to what we need to get our act together. I'll hand it back to Arnas.
I would now like to call upon Dr. Pavitra Mohan, who is the moderator for the panel discussion, which will have Dr. Evita Fernandez, Mr. Anas Wajid, and Dr. Murthy on it. Over to you, Dr. Pavitra.
Thanks so much, Naz, and thanks so much, Dr. Murthy, for that fascinating and exhaustive presentation.
Dr. Pavitra, you're not clear. Can you come closer?
I might need to.
You may have to increase your volume, Pavitra.
Yeah, let me just. Better now?
A little.
Okay, let me then just take off the...
In general, you're a very gentle speaker, so you have to shout a little more.
Okay. Um, is it better now?
Yes.
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 Okay, okay, I'll speak without the speaker. Yes, thanks for that fascinating presentation, Dr. Murthy, for very exhaustive, providing a lot of frameworks of how to manage and be prepared for pandemics. And I was also reflecting just now that we're coming to the end of this year, and many people will be happy to see the back of this year. And it's also time for greeting and for preparing for the next year. And in that context, I was thinking that there are a few things that seem to be giving us some reason for cheer. One is what Dr. Murthy showed the graph for India, where the cases of COVID seem to be coming down consistently since mid-September. There is also now at least possibilities of some vaccines which would probably be helpful in some settings and would at least decrease the fear around the epidemic. There is also seems to be a gradual resumption of health services. I think one of the major casualties of the epidemic was also discontinuation of many services, leading to an increase in decrease in access to services and increase in prevalence of several conditions like outbreaks of malaria, increase in tuberculosis, etc., in several regions. And there seems to be some gradual resumption of services. That's also good news. I mean, if one has to look at some cheer in this amidst the gloom of the pandemic this year. However, I think when we look back there, we also realize, as Dr. Murthy said, that we were all caught unawares globally, but more so in a few countries where the pandemic caught us unawares, and the way we managed it left a lot to be desired. We would not want to repeat it next time. But also one thing that I caught from Dr. Murthy's presentation was that the investment in healthcare per se is important. It's not only important to prepare for a pandemic, but how do you build effective and resilient health systems is what would help prevent and manage any future outbreaks at the national, global, or a local level. So I would continue from there, Dr. Murthy, and would ask you to say that, while all this knowledge was available, I saw there are a lot of references that you shared were of before 2020, right? They were ranging from 2002 to 2020, where a lot of framework, a lot of preparedness manuals were available. But still, it left a lot to be desired when we were actually hit by the pandemic. You showed the first few months were critical, and subsequently as well, they continued to rise, and there was a lot of confusion and chaos how to coordinate the whole process of response. So if we were to look back and learn from it, in not to say that what went wrong, but how would you think that we need to be prepared better for the next set of pandemic? We know that there are thousands of other viruses floating around, and some of them can cross over and may cause either a local, regional, or a global outbreak. So what would you think would be the key things? And specifically, I would think that while it is a pandemic, ultimately it plays out at the national level. So for India, what would you think we would need to do differently and prepare now between it is still not the inter-pandemic phase because the pandemic is still ongoing, but considering that it will now have a downward trend and would be eliminated. What should India as a country do to be better prepared next time anything like this happens, or even in between? Because we know that this is not the only epidemic that hits the country. I mean, maybe at the nationwide, this was the first major one for a long time. But there are smaller outbreaks and endemics and epidemics that keep on breaking out in different parts. So how would you, what would you think that we need to learn from this, the management of this epidemic, and to prevent future epidemics of this sort or of different sorts?
Thank you, Dr. Pavitra. I think this is a very relevant in the present context. I'll just take everybody back to what happened with me personally in January. So I was traveling to London on the 25th of January and returned on the 9th of February. And I took a Sri Lankan Airlines flight because there's a good connection from Hyderabad. On the 25th of January, the entire crew on the Sri Lankan flight was wearing masks. They were serving the entire flight with gloves, and keeping a distance while talking. Not just on the 9th when I returned, this happened on the 25th. At Colombo Airport, the entire staff was wearing masks. You see that impact today in Sri Lanka, which has had much lower intensity of the outbreak compared to its neighbor, India. So we had that 12 weeks time where we could have prepared, taken it more seriously, and people coming in from international travel, including me, who then came in because I came in early in February, having gone through a drill of consistent uh, isolation or quarantine, unlike the way it was practiced where people disappeared. This is not an indigenous outbreak. This was an imported outbreak. And therefore, we had that 12 weeks to prepare for that outbreak with a lot of measures. But those measures can only be in place if you have a public health response to outbreaks. We don't have a public health cadre in this country. And when you look at the way we have fought, ICMR takes a role, the NCDC, which is the equivalent of the CDC in India, that plays another role, and the Niti Aayog plays another role. So there is no nodal mechanism for putting all the public health measures together. Now, for us, it's public health, but for the society, it is developmental. So everything that happens at the public health level also has an impact on the developmental indicators. So we have to have a public health workforce. You cannot have a non-functional primary healthcare system to help us fight. So we have to have more robust primary healthcare systems if we have to make a difference for the future. But the biggest thing that we have to look at in terms of a takeaway is the appropriate thing of having a public health cadre. We used to have an Indian medical service which used to play this role in the early part of the century, but that got disbanded. And I think we need to look at some sort of a cadre of that nature, because you need the skills. You need surveillance skills, you need modeling skills, you need prevention skills, and that everybody does not have those skills. You need somebody who's focused on those skills, and we have to invest in that if we have to make a difference. The second important thing is in terms of sharing of information. Unless there is transparency, there is not going to be confidence. If you know that the information that is coming out is transparent, that is the real caseload, then you are better prepared. People should have confidence in the information that is shared, and only then can evidence play a positive role. And this is for pandemic control. If countries do not get the real-time picture, they can't plan. And one of the important cornerstones of pandemic control or pandemic preparedness is to have a transparent information sharing mechanism. So we need to invest in that very, very carefully. The third aspect is more developmental. Let's not look at a pandemic as only impacting the health system. Look at the education system. Children not going to schools. Children don't go to schools only for textbook knowledge. Schooling is an experience. It's the peer interaction. It is the interaction with the teachers, for many of our children, midday meals, which provide at least half their calorie requirements, is something which is very, very critical. And when you look at children with disability, along with people with disability, a child with cerebral palsy needs rehabilitation support. Parents can't manage them if there is no support. So we have to prioritize. Going forward, there needs to be some sort of ring fencing mechanism that people with disabilities, children, widowed women living in the rural areas, that we have some form of an access net for them, a social security net. If we have that, a lot of these problems that people faced during the lockdown could have been reduced, and it could have actually made a very big difference. So we have the wherewithal, and I don't think money is an issue. At the end of it, you have to take the civil society along, the private sector along. If these two sectors of of our society are not involved in an epidemic, outbreak, or pandemic response, then you are going to miss out and duplicate those sort of responses. We need to see that we bring all these together onto the same platform. Dr. Pavitra, these would be some thoughts. There are many others, but then we have so many luminaries from whom we can learn on this panel. Thank you, Dr.
Thank you so much, Dr. Murthy, for those extremely insightful comments. And, talking of Sri Lanka that you referred to, Sri Lanka, a couple of years ago eliminated malaria in the entire country. And that was not through a vaccine, because we still don't have a vaccine for malaria after all those thousands of years. But by sheerly having a strong primary healthcare system, they were able to, treat early detection, treatment, and larvicidal measures that helped in. And that is reflected not only in malaria, but also in. So I believe that a strong primary healthcare system can address not only the one disease or other at a time, but is better prepared to manage. The other thing you raised about education systems, and I'm so glad you talked about it, because I think this closure of schools, the areas that we work in, we're seeing that children as small as 12 to 14 years, for whom it was in any case difficult to stay in school, are now out of school, and many of them are now entering the labor market. And one wonders whether they would ever be able to come back next year when the schools open, because they would have been sucked in by the market and the necessities of the family and community. So yeah, better preparedness not only for health systems, but more community-based and more empathetic systems would broadly help. So thanks for those insights, Dr. Murthy. I'll go on to Dr. Evita, who has been very closely looking at what is happening to women's health during this period. And even in normal periods in India, Dr. has been promoting a lot about respectful care, which is something which should be something which any developed, any civilized society should be absolutely basic, that a woman who needs health care or who needs a safe childbirth is often not treated with respect and dignity that she deserves. And during epidemic, not only that dignity was denied, but also just sheer access to a safe environment was out of bounds for many, many women. So, Dr. Evita, from where you are, from your vantage point of looking at women coming or not coming in labor or for other healthcare needs during the pandemic and how it was affected, what would you think we need to learn from it, and to ensure that in any future similar or a different emergencies, could be of different kinds, but especially an epidemic or a pandemic of this nature, how do we ensure that women are not denied access to respectful care that they deserve at all times, including in epidemics, and we are not just left to vagaries of an outbreak or an epidemic to say that okay, it's okay for women not to have that care. So what have we learned, and what do we need to do better next time around?
You're muted, Dr. Evita.
Thank you, Pavitra, for the question, and I thank Professor Seshadri for inviting me to be on this panel. I've been listening to all the talks all through the morning. Pavitra, before I answer that, I think it's important we set the background for our listeners. What is the impact of stopping everything connected with reproductive health services, starting with conception, that contraceptive advice, over-the-counter contraceptives were not available, everything was shut down. So then you're talking about pregnancies that may be largely unwanted. So that's linked with abortion services not being available. And those who are pregnant when lockdown happened and everything shut down, where do they go? So you're talking about anxiety, fear, and 20% of these mothers with complications may or may not get the care that they truly need. Then you go on to childbirth, and you've touched the very point that I wanted to raise about respectful care. So if they do have to birth, hospitals, people were afraid, women were afraid of getting infected, or the hospitals where they were booked shut down. There was a lot of fear. So, and then babies, and as a pediatrician, you face that, immunization was put on hold. So added more to the anxiety. Apart from all this, we know that the C-section rate had also increased because protocols were changing so rapidly. We still weren't sure how to birth women. In our own city in Hyderabad, we've got designated hospitals for positive women. So they had to go to these places. We couldn't help them. So as a result, most of them ended with C-sections. So we know that's an unnecessary intervention. And compounding all this, mental health issues, particularly among pregnant women and postpartum. Why postpartum? We know because if a woman has had a traumatic birth where she's experienced disrespect, abuse, discrimination, and we also know that mothers have died because of this, when they were afraid that they were taking COVID positive mothers, women were being shunted from one hospital to another. So this whole journey of motherhood was fraught with a lot of anxiety and terrible stories that affected women, because we all know in any calamity, it's the women and children who are affected the worst. In Fernandez, just to very quickly say, we have a load of 10,000 babies a year, with roughly about 875 babies born a month, and 26,000 footfalls of OP. So when the lockdown happened, the first 10 days, we were just contacting mothers, rebooking, assuring them. And meanwhile, the whole of April during the shutdown, all emergency services were stopped. We got ourselves trained into different teams, protocols, training virtually 24/7, restructured pathways in the hospital. And by the end of April, early May, we were back on track. So today we are at 98% of our services, which actually kicked in from June onwards. And I don't want to repeat, but all of us have used telehealth and reduced the unnecessary antenatal visits. The people who were hit really, we felt, were people outside the city. And I think people, in smaller towns who were booked with us, particularly women with complications, they didn't want to travel. So that load dropped. And we tried to sort of link up with doctors outside the city limits and create a network. On the national level, and this is even more chilling, because unless we understand this, we wouldn't know what to do next. Because all services were stopped, the Foundation for Reproductive Health Services, India, says that we will have an additional 38 million in unintended pregnancies. Our average birth rate hovers between 24 to 26 million a year. So they reckon we're going to have another 38 million unintended pregnancies and 700,000 more births, 1.45 million abortions, of which they feel 800,000 may be done under very dubious circumstances, and maternal death will increase by 52%. With babies dying, child mortality may increase by 40% because of immunization programs being on hold. So the impact on a woman and her baby is going to be horrendous. What did it do to maternal health in other ways? Where there was supply, women just didn't know where to go because there were very few hospitals designated. And we now know from the data that has come out, pregnant women, unless she's got some morbidity in terms of being a diabetic or hypertensive or pre-existing medical complications, on an average, largely healthy women are not at any higher risk of getting infected. So even the UK, the NHS has changed its protocol. They are encouraging hospitals that have asymptomatic women who are positive to be looked after in those hospitals. Don't send them to the large tertiary hospitals because only 1 in 10 need ICU services. So we need to keep this in mind when we are looking further ahead to plan. We're looking at a pandemic of this sort. So in the demand side, where should women go? Because there were not enough COVID designated hospitals. And we were not wise enough to know what we know today. In our own Fernandez, we've got 3 hospitals. And we went through a lot of soul searching ourselves because I thought we need to be there for our women. But we realized that the incidence of positive cases in pregnancy was actually very low. And if we were going to convert any of our hospital, even a whole unit, we would have been serving a small population and actually shutting our doors to a larger group that would have accessed the hospitals. So a decision was made that we will continue offering our services and make it more accessible, make sure that women have birth companions where most of the hospitals did not allow birth companions. So we tried to offer respectful care, and that is so important for us to remember in our planning, that fear cannot make us lose our humanity. Compassion has to be there as the basis of all that we do. Why am I so passionate about the fact that pregnancy has to be treated with such a sacred responsibility? Because you, as a public health person, will know that for a large number of our women, the first entry into a healthcare system is because she's pregnant. And if we don't get that journey right, we've lost it. And we are looking at these young women who are not accessing healthcare during their pregnancy. If she's not a healthy mother, she's not going to give birth to a healthy baby. And if she doesn't get respectful care or safe, skilled care, she may lose her baby. So your stillbirth, your intrapartum deaths, you may get hypoxic babies being born, you may have a higher morbidity, mortality. So if we don't get birth right, nothing else matters after that. And if we get birth right, then we've got a healthy mother, healthy baby, and the next generation is starting off on a good note. So pregnancy obviously cannot be put on hold in any calamity, and birth of these babies has to be treated with such responsibility. So what would we do differently? Gosh, I wish I had the wisdom of Dr. Murthy and the courage, but I definitely do feel, and I'm sure everybody agrees, we cannot stop reproductive health services because of a pandemic or a calamity. We cannot, and I think that's the first thing the government needs to realize, that we did make a mistake there. And I'm absolutely convinced that our primary healthcare system, we all know, has failed us. But if there's any strengthening from my perspective in terms of mother and newborn, you definitely need professional midwives forming the backbone of our primary healthcare services. Because if you've got a skilled worker at the very end of that line, even in a tribal belt, and she's given all the skills to take care of majority of the women, she will recognize complications early, refer the woman. So we've got to give her a good referral system, a support system. So at the end, your complications are picked up early. Basic emergencies, she's skilled to handle, and your tertiary hospitals are not filled with unnecessary volumes, which happened in our cities. There were no beds. Today, we know that asymptomatic COVID positive women can be treated safely in smaller hospitals that are trained with protocols and isolation pathway, because the need for these women to be in ICU is very little. And this is where public and private partnerships need to be strengthened with that respect and trust. We know a lot of hospitals have offered CMC Velo, St. John's, a lot of trust hospitals have come forward, but they're incurring heavy losses also. because the government has not helped them in any way to cover their costs. I'm not sure how they're handling it, but the point is that we need to work together, public and private, using the strengths of each other. Standalone maternity hospitals should be the new tomorrow. Wherever you've got maternity services as part of a hole in the wall in a multi-specialty hospital, because obstetrics is not a money-making unit unless you have a very high C-section rate. But if you're absolutely committed to doing the right thing, your C-section rate would be below 20%. So it's not much money making. So in a multi-specialty hospital, it's probably a hole in the wall. And mothers don't have to go into a big hospital to birth. So standalone systems need to be built, and smaller hospitals closer to where women live, because women are not going to travel anymore. I'm convinced, LVP model has shown us that they are taking more and more high care services to the periphery. You know, they've now realized that they can do it. How can we do this with birth and reproductive health services? You know, I think institutes should team up with NGOs, with other services. Like, I would love to work with you and Sharath, if we can, and strengthen the services that you are offering. So I think in relation to this, that is important. And of course, telehealth forms a very major part of this care, because we realized that for several months, it formed about 35% of our OP services. But now, as things are easing out, women are not that keen on going in for telehealth or telemedicine. They would prefer a face-to-face visit. And unfortunately, we are still battling with that, because we don't want to let down our guard, and maintaining social distance is important. Finally, your primary health care, your PHC can be strengthened with skilled birth attendants. And I put my money on midwives. And
you're muted again, Dr. Evita, though I think you're muted again. I think it's also probably just got into self-mute because your time was also over. So.
Okay, fine. I
didn't do it, but I think the system.
I only wanted to say that we just need to be conscious of the fact that 30 million people are going to be pushed into poverty. And whatever healthcare service we're going to offer, we need to be aware of that the paying capacity of people is going to be less. Thanks.
Thank you so much, Dr. Evita. It's always so amazing to listen to you and to your enthusiasm and your compassion for women everywhere, and the respectful care that you often talk of. And I think one of the and I think what you said about that fear cannot make us lose humanity would remain with me and probably with many others for a long time. I think that the focus that you talked of on decentralized care, on primary health care, on standalone maternity units, etc., is extremely invaluable insight. And I think this is something that we need to probably also explore a bit more. And we've been doing some work, including our own work, where we found that even during the peak of COVID, the decentralized health services, which are closer to the community, continued to provide service, and in many cases were extremely helpful also in containing the epidemic while doing so, and in building the trust that Dr. Murthy talked of, which is so essential when faced with an emergency, but also in normal times. So thanks for emphasizing the need for that while you talked for it in context of maternal care, but it is so essential to have more distributed care, and especially for women, probably it becomes even more important, because we know that women in India have much lower mobility, much lower autonomy to move away from where they live and travel long distances to seek care, as opposed to men who still might are more mobile and are more able to access care. So thanks so much for that, Dr. Evita. And I'll come back to a very different context altogether and welcome Mr. Wajid. DVR did as always, eloquently and introduced all of us. So I would not reintroduce you, but you all know that you lead the sales for Max Hospitals, who, from what I understand, have continued providing services, and also probably in many places partnered with government to provide COVID-related services. So one of the questions for us who come from a very different context would be very interesting to understand that how did you ensure business continuity while faced with such a pandemic? And I'm sure the second question would be that if you were to do it differently next time, what lessons you came your way? And the third, though I'd not planned it, but that might be maybe we started with you, but then also maybe back with Dr. Evita did mention that a bit about the public-private partnership, and for you especially, how well did it work during this time, and what lessons, if you were to then go back to the government and say, hey, you need to do it differently, what would that be?
Pavitra, if before Anas talks, I want to tell one very, very special aspect of him, which I hope will be trailblazing. We are trying to write a case about it. Some years back, he decided that the whole tertiary care had a lot of unsavory practices, such as, let me put it crudely in this small group, we can talk, kickbacks to the hospitals for referrals from doctors or referring to, the tests that are conducted outside the hospital and so on. And with his stewardship, he decided to put an end to it. And thanks to his leadership, he convinced the board. And today that hospital has totally come out of this terrible practice. And that has in fact increased the footfalls because the community has realized that these people are, like all of you on this panel, 24 karat gold. So with that, over to Anas.
So good afternoon, everyone, and Dr. Seshadri, thank you for those kind words and for inviting me to this session. Good afternoon to all my co-panelists as well. It's been wonderful listening to all of you. So let me try and answer Dr. Mohan's question first, and start with a small anecdote. It was New Year's Eve last year when, in a conversation, I remember the first time we heard or we thought of COVID hitting our shores. We've been kind of getting news, etc., from China on how things are moving in Wuhan and other places. And then that was the conversation with the director of medical services at Max Healthcare. He said, we need to do something and at least be prepared. Post that, the whole of January until the middle of February, like Dr. Murthy also mentioned, sadly, we didn't do much. We just kept absorbing what's happening in the world. We were all shocked at what was going on. But it was only in mid-February when the first set of cases started kind of being noted in India that we kind of woke up and said, let's get on with it. And that's where the whole thing started. From a business continuity point of view, the first thing is that the leadership team decided, and that was a big question on the table, saying, what role do we want to play in this? Do we really want to be part of this? Or do we just stand back and let the government, the public sector, etc., handle this? Because, they're probably better equipped to do that. They have a bigger reach as well. I think the leadership team of Max Healthcare took a call, and relatively early as compared to other private operators, saying that, look, we need to be a part of this. There's no way that we can't be. It wasn't really a choice in that sense. And therefore we kind of started preparing seriously for what lay ahead. Now, one of the critical and central things in ensuring our services continued unabated was the recognition of the fact that the most precious asset in these times would be the healthcare workers. Those are people who can't be replicated overnight. Those are the people who are at the greatest risk as well. And therefore, the problem was, how do we protect them? How do we ensure that they remain motivated and continue to serve in extremely difficult, trying circumstances that seem to be coming up? And therefore, we kind of started working with them first. Next came infrastructure. So while everybody had told us how contagious the disease is, how quickly it spreads, there were all kinds of, and I must say with hindsight now, a lot of exaggerated kind of discussions on on how dangerous it would all be for healthcare workers. So infrastructure was our second big concern, saying how do we fix it? How do we isolate? How do we create large isolation areas in busy hospitals who were dealing with all kinds of illnesses from high-end tertiary care work, including transplants and high-end surgical work, etc. That was the second big piece, and therefore a lot of thought went into isolation areas being created in the hospital. Fortunately for us in Delhi, where we have lots of facilities, we decided early on to dedicate one entire hospital for COVID. And that, I think, was a very good decision to take. And we were we saw that having a separate facility, a large 250, 300 bed facility only dedicated for COVID was a great idea. And that's what we created. It was easy to isolate one large hospital than trying to isolate a few beds in different hospitals or a floor or something like that. We were forced to do that later when the pandemic really started and there was need for more number of beds to be dedicated. But the standalone hospital was very useful. Thirdly, we were shocked to discover that, the protective equipment that was required, we hardly had any supplies. We just were not prepared for this. I remember a day in early April, in the middle of the lockdown, we had PPEs worth 2 days of operations, and we were wondering, what do we do? How do we put people in wards where were infectious patients without proper equipment? We were scrambling to get supplies from China. There was discussion going on saying, should we hire aircrafts, etc., to bring in supplies which were not then readily available in India. I think that was a very, very difficult situation to be in. The same applied to a large extent with some medicines, etc., where we were running short on supplies, but those were replenished much faster. So PPEs was a big issue, actually. Well, apart from, these elements of business continuity, there was a big concern about while we started operations and things started spinning out of control, we had lots of people getting infected. The staff rostering, it sounds very boring and mundane, but that's extremely critical in a period like this, because we had to isolate these people who were working in the front end. We had to ensure that they stayed in the hospital while they worked there. They stayed there, and they were kind of quarantined for 15 days post their duty hours. So they worked for 15 days, then they quarantined for another 15 days, but none of them were going home. We had to make arrangements for them to stay in the hospital, and all the supplies that are needed in the hospital, how are they to be procured? So these were big challenges. I think we learned as we went along. Lastly, but not, just as important, clinical protocols. These were just not available. Nobody had really thought about writing them down, publishing them. So our clinical teams very quickly got down to writing these. They were able to put together a very comprehensive set of clinical guidelines. And by the way, these have kind of over the last 7-8 months evolved as we've learned more about the disease and its management. But the first set of clinical protocols were very hastily needed to be put together. Once we had put them together, we actually published them we published them on Twitter and other platforms, so that those other hospitals who might be struggling with these problems can benefit from that. So these were really the big issues that we felt on I would say in terms of business continuity. But there were problems outside as well, that we faced. Particularly, there was like Dr. Murthy also mentioned in his presentation, complete confusion on policy. There were too many players giving direction to hospitals on what to do. So we were on one hand getting directions from ICMR, we were getting direction from Niti Aayog, we were getting direction from Ministry of Health, which in Delhi, we were getting direction from Ministry of Health of the Government of Delhi. There were just too many people involved, and all of them kind of were not coordinating anything. There are too many directions coming in. You need so many beds for this. You can test this person. You can't test these people. Somebody needs to be mandatorily quarantined. Somebody needs to, all the information that regarding testing needs to go in some place, etc., etc. So a lot of time, effort, energy was wasted in trying to figure out what needs to be done and who is really in charge. And that was a very, very difficult problem and it continued to kind of harm us, hassle us right till I think the middle of August, September, or maybe a little by the end of September. I think things settled down. It took a lot of time to figure out what really the government wants us to do. And finally, I think a big problem that we faced was that there was no dialogue. We were in a very strange situation, which is the private sector hospitals had a big queue of patients outside their doors. All of us were struggling to handle those patients. Many actually did not need hospitalization, but the government policy said that anybody diagnosed with COVID needs to be hospitalized initially. Then they said that the person needs to be put in a special home kind of a thing, and these homes didn't exist. And then suddenly government started taking over hotels, etc., and told us to put these patients in hotels, as if this was something that can be done overnight. So all these problems were lack of dialogue with the government, confusion in matters related to policy, etc., kind of caused a lot of stress, I think, which could have been easily avoided if we had a more coherent and more thoughtful response to the problem. However, I think much of it is behind us now. We've learned a fair bit, and therefore, to answer the second part of your question on what we would like to do differently. One, we would certainly want to be far better prepared than we were this time. We would like to stock PPEs perpetually, and we've started doing it, of course, because that's a very, very basic requirement. In our hospitals, in large private hospitals, including ours, imagine we did not stock more than 50 PPEs. We had very few because we have infectious wards and things like that where these are used, but very few. They wouldn't last us more than a couple of days if we were to face a pandemic. Therefore, we started stocking materials. We started stocking medicines that will be required, and we would like to carry an inventory for a significant period of time. Whatever the cost of that inventory, etc., is, doesn't matter. We would like to be better prepared on that front. From a treatment and clinical point of view, I think while our teams did a great job in being able to write clinical protocols based on whatever information was available and coming from the West at that point in time, where Spain and Italy and other countries were reeling with the onslaught, I think what we would like to do now is put together all this information as a repository for this disease, and also probably start looking and working a lot earlier. Maybe we wasted about 4 to 6 weeks in the initial phase, and that was also Dr. Murthy was saying probably that happened. But we would want to start a lot earlier from a clinical point of view. Thirdly, we would like to train more of our people to be able to cope with what a pandemic really means and entails in their lives. The healthcare workers that have been handling the crisis, hats off to them. They've been fantastic. But as I said, all of us learned on the job. They were not really prepared to be in PPEs for 7-8 hours, to be staying away from their families, risking their own lives. All of this requires a bit of preparation. It also requires a bit of mental adjustment, for people who are facing this. We kind of were able to support them later, but I think it would be better if we were to do this on a continuous basis. Pandemic, epidemic, no, nothing. We should continue to engage in doing and training people continuously, because this may or something similar may happen next, and therefore that would be very, very important for us to look at. Lastly, I must point out, and I say this with regret, while the government and whatever they did, I spoke about it earlier, unfortunately the community's reaction, and it's been highlighted by other panelists earlier in this conversation, was actually quite disappointing. We had problems in finding accommodation for our nurses, because hotels, hostels whom we contacted would refuse to take them, saying that they posed a great deal of risk to their communities, etc. People would struggle. We had situations where resident welfare association office bearers turned away our people, saying that, look, we can't put them up in hotels because they needed to be staying away from their homes in communities near the hospital so that they can easily commute and so on. I think that we need to be far more vigilant. We need to inform the community of what it entails and what it means to be fighting a pandemic like this. We need their support. These are people who are supporting the communities. We would get stories about nurses being kind of facing problems at their place of work, in their hospitals. Now, some of them will, and there is, of course, an element of risk. One is not denying that. But the fact is that without the support of the community, it becomes so much more difficult to handle a pandemic like this. I think we need to do a lot more in informing the community, in educating the community, in seeking their support, and kind of working with them rather than working at cross purposes, or kind of they being afraid of healthcare workers of all people. It's rather ironical that they would be more than happy to come to the hospital, God forbid, if they fall sick, and take the services of the same set of people, but they won't let them live in their own communities. This was extremely disappointing, and I think we need to do a lot more in educating people over a period of time on the importance of community support. I think those really were the big ones. I hope that answers the question, Dr. Mohan. Let me also now address the third question. About, I spoke about what happened with the government, but we can certainly, and we particularly feel that during a pandemic, or during a situation like this, there's got to be one authority. While one understands that we are kind of constructed as a health being a state subject, and therefore the states in which the hospital is located, the policy there, but in abnormal circumstances like these, I think it's important that there is one single authority populated with suitable experts, both from the public health side as well as the private healthcare provider side, who are working together, hopefully, to be able to kind of handle this, and there's no confusion at that level. That's one. Two is there was a lot of issue. There was hardly any dialogue. You were just told that you need to have 50% of your beds blocked for COVID patients, 80% of your ICU to be blocked for COVID patients. No one is telling us what do we do for non-COVID patients. There are cancer patients in the hospital. There are patients who have other urgent medical needs. But there's complete silence on what do you do with them. And therefore, there was a very sad lack of dialogue, lack of communication not only between the arms of the government, but between the private and the public sector and the government. And that shouldn't happen. I think there should be an institutional mechanism that needs to be set up where these dialogues can happen fast, and there is alignment between all those stakeholders who are providing healthcare services, particularly during times such as these.
Thank you so much, Mr. Wajid. That brought several, new insights into the discussion, and especially I think you focus on the health workers per se and addressing their fears, their concerns, training them, and also keeping them, motivated, supplied, etc. was an extremely, I think useful insight while dealing with such a pandemic, and also your frank kind of expression of how it worked with the government and with multiple agencies, and what it meant for running the services smoothly amongst all this confusion. So thanks for being candid there, Mr. Wajid. They're extremely useful, because I think moving ahead, we need to be really look back and see what really worked well and where we need to work better, both we ourselves as organization and institution, but also how we ask the governments to improve the way the governments coordinate with the other sectors. And Dr. Murthy, you wanted to add something on the resource optimization during pandemic. So we'll do that and then come to some of the questions that have been raised.
Right. So I think what we saw during the COVID times is, one, you had the National Epidemic Act being put in force on day one, but then there was nothing to follow up on that. And therefore, every state started building up, stockpiling ventilators, right, left, and center. And the reality is today, in fact, we had advised 2 states, we had worked out what proportion of the population would need ventilatory support and how many they can actually look for. But they just went ahead and purchased right, left, and center. So one of the things, if you have the National Epidemic Act in place, that should be done is that certain high value and critical equipment should form a common pool. Every part of the country does not have a pandemic at the same point in time. there is always going to be a difference in the outbreaks between Maharashtra and Tamil Nadu, between Tamil Nadu and Andhra, between Andhra and West Bengal. So if you have a national pool of resources specifically for critical equipment, then you can actually use the mechanisms to transport from one place to the other wherever the epidemic is breaking out without having to have all that equipment rusting in exactly a year. And believe me, that is what is going to happen. A lot of the equipment that has been procured is going to go into the waste bins within a year. So that is not optimization of resources. We need to plan, think differently in a future epidemic.
Thank you so much, Dr. Murthy. I think there was only one question by Jagdish about the numbers of the numbers that Dr. Evita quoted on the additional births and the additional deaths due to denial of reproductive health services. And there has been, and I think Rahul also shared the link to so please do look at that report. There are also similar modeling done for many other conditions like tuberculosis, deaths due to tuberculosis, which says that there will be additional 500,000 deaths between 2021 and 25 because of tuberculosis. There has also been projections for cancer and other conditions. So please do look at that. I think one of the things, since we started that about the coordination with the government and the trust, I would also like to just hear a bit about the experiences, Dr. Evita and Dr. Murthy, about how you think that it played out, and again, what can be done better to coordinate there. So maybe, Dr. Evita, if you would want to go first.
Pavitra, could you repeat the question? I wasn't sure what you were wanting.
Okay, so the question was that, as Mr. Wajid pointed out, that there had been confusion. With partnering with the government during these phases. So both during the epidemics and even otherwise, when we are looking at a larger institutional mechanism that Mr. Wajid spoke of a public-private dialogue, what has been your experience and what would you suggest?
I do share what Mr. Wajid has expressed, because we felt we could have worked better if there was dialogue between the government and private hospitals. For example, Pavitra, we had no access to testing till June. So between March and June, we had no idea. At the same time, you couldn't test everybody just because you were afraid. So we had to sort of, decide who goes for testing, what kind of mothers do we send. And it was so difficult to even get a swab done because private, swabs from private hospitals were not being accepted. So what happens to mothers in these institutes? A simple thing like that. So I definitely feel during a situation like this, more so during a crisis, a national crisis, the government should talk to private hospitals and get them in and work in unison, because a lot more can be done, certainly.
Thanks. And Dr. Murthy, your experience, not as a service provider, but maybe as a public health institution of a dialogue with the government to manage the epidemic.
No, absolutely. Like I said, 2 states had asked us, one state's planning commission asked us to help in modeling, which we did. But then the final decision, if it is to be taken on political compulsions, then it doesn't augur well for any sort of thought out process in terms of a pandemic control. But the fact is, the ICMR is a medical research institution. Right? So the wording itself is very clear. The Niti Aayog is a planning body, and the National Center for Disease Control has disease control in its name itself. So what is it that is confusing? Because if you have authorities set up, then you have to vest those authorities with adequate power and responsibilities. Well, if you can't do that, and if you want everybody to go out like the amoeba and go out in all directions, then there is going to be confusion and chaos. The other thing that is important, and I think that comes from, I've been in the government earlier, so I can completely understand that inbreeding does not bring in lateral thinking. And when you have somebody who joins at one position and then goes on to become the director of health services because of seniority, there is inbreeding, it does not bring in any fresh thought. So maybe going forward, it is important that this coordinating mechanism or role or coordinator need not be the head of a particular institution, but it could be somebody who has the reputation of having dealt with problems of this nature, whether they're in the private sector, the NGO sector, or government sector, is immaterial. That particular person has the bandwidth to be able to take everybody together, and that person should be designated as the national coordinator. And that's not in our case. Dr. Fossey had to unfortunately leave because the political dispensation did not believe in him, though everybody else in the health sector believes in him. So we need somebody like that to be the coordinator, to bring trust and bring all stakeholders on a platform. It does not have to be somebody from the government. And I think about that very, very seriously. And that may be the way forward for bringing all sectors together in acting in future outbreaks.
Thanks, Dr. Murthy. Dr. Evita, there's a question for you from Sanjana, who says that there is a huge need for strengthening systems for providing uninterrupted reproductive health care. And looking at women who have limited autonomy, limited mobility, especially in many, many communities. So what is the role of men that you see there in ensuring, respectful maternity care? Where do you see men playing a role?
Thank you, Pavitra. One of the problems we actually faced, Pavitra, was, we took this decision to restrict visitors and people accompanying mothers when they came in for antenatal care, because we didn't want too many in the room and, social distancing and things. But today we're actually thinking that's not a good idea, because one of the biggest anxieties faced was having the partner outside and the woman inside, and even engaging in conversation. Of course, we tried to use mobiles and things, but I definitely feel engaging the men into the whole journey is a good thing, because they are a great support. You'll be surprised how many husbands actually ask the number of questions. They come with a checklist and they're more involved, and they probably end up asking more questions than the woman herself. And to me, that's a good thing. And if they can be that support for their wives, I think it's extremely important. That's why today we're going back on that decision, and we're getting them, we're also thinking of bringing them back into the scan rooms so they're more involved in what's happening. I hope I've answered your question.
Thanks, Dr. Evita. There are no more questions as of now, but I would maybe, if anybody has any final comments, and then I would try to sum up in a few minutes of what we've kind of learned during this session. Yeah. So any last comments? Maybe on my screen, Mr. Anas Wajid is the first, so we move from left to right. Any last comments?
My only comment would be that the most critical thing that we've learned in this is that we need all the stakeholders to work a lot more coherently than what we've seen in the past. That's one. Two, we need community involvement a lot more than what we have seen in the past, and we need greater set of support for doctors and nurses, etc., who are toiling away in very difficult circumstances. I think that's something very, very critical. And thirdly, we've seen a lot of demonization of private healthcare over these past few months. That's obviously very demotivating for all of us, because we, at the end of the day, have handled the bulk of patients who have fallen sick. For better or for worse, there is something that we've done and will continue to do, and therefore a little bit of appreciation would be very useful. Thank you.
Thank you, Mr. Wajid. Dr. Murthy.
Thank you, Dr. Pavitra. Couple of important takeaways from the discussions that we've had here is that what I referred to earlier, resource optimization, is critical because it brings together whatever shortages there are in one place can be tided over. Like somebody had it in the question and answer box on if there is a national calamity, should the national activities supersede state level structures? It's not about supersession, it's more about coordination, working together with one fact in mind. The most important thing, takeaway for me, is the fact that it cannot be a political solution. It has to be a public health solution. The political dispensation has to listen to advice and wisdom of the public health specialists. And I'm talking about public health, it doesn't mean one discipline. Anybody who's concerned with the health of the population, with the good of the health of the population. If I have to look at an eye care program and somebody to lead that, I'm not going to look at only the director of blindness control. I would look at somebody like Dr. G.N. Rao to have the bandwidth to look at that coordinating role and play a much more important role because they can bring all sectors together. If it is something on reproductive and child health, I'd like to have Dr. Evita to lead that rather than having somebody in the government of India who is very junior, does not have that sort of networking to actually push it through. Political power can't make public health decisions. And I think that is something the country has to realize going forward. If we do that and give adequate space for all sectors, then we would have done some good and learned some good lessons from the pandemic. Thank you, Dr. Pavitra.
Thanks so much, Dr. Murthy. And just on a lighter note, that if I had a choice to make someone a health minister, I would really want you to be there so that you can bring about all these changes. Thank you so much for that, Dr. Murthy, but yeah, extremely helpful. Dr. Evita, last comments from you.
Yeah. Thank you, Pavitra. I think I would, plead for a better understanding between government and private sectors, that we work together with more trust and respect, using the strengths for the larger good. The second thing, I feel those of us who are privileged to run our own establishments have a much bigger responsibility as we head into the new year, being acutely aware of the impact of this pandemic on the lives of people in terms of spending, in terms of accessing healthcare. And, so we just need to be more conscious of our billing structures, what we are offering, keeping it to absolutely evidence-based, cutting out all the stuff that is not required, because I think that's a huge responsibility, and it calls for a lot of introspection and remodeling our work so we're more cost effective and less expensive for the users.
Thanks so much, all of you. I think one couldn't have a more engaging conversation than what we had, and more insightful and more honest and more expert opinions from what we've heard over the last 45, 50 minutes that we've been talking. Thank you so much, all of you. I've just tried to put together a few, summary of some of the discussion. And to me, some of the things that really at the meta level stood out, I think the first thing to me was the trust. I think we discussed a lot about trust between the government and the private, between different agencies of government, between providers and communities. Right? So I think trust is such an important but an undervalued asset that one talks of. And I think how do we build trust between institutions and between institutions, whether they are government or private, and communities. I was just kind of struck by what Mr. Wajid talked about, the nurses not being accommodated in the neighboring communities. So I think going ahead, we have to, and at all levels, and I'm not talking this only about a private hospital or that example. It has happened in all of our communities. We run a clinic in one of the very remote communities where, when we were continuing the services, people from that village came that, but there are so many people coming from other villages. Why do you want them to be treated here? Because they can bring in infection. So how do you bridge that trust divide overall amongst people and between providers and communities around it? I think we have to do some introspection, as Dr. Evita said. Trust does not happen. You can't demand it. You can't complain about not having trust. We have to actively build trust. It's something I think that we all need to foster at different levels at different places. The other is a issue of which is and trust is, I started with trust because that underlies the coordination and communication. It cannot be a trick. You can't just coordinate and communicate without having the trust, investing in building those trustful relationships. And that would probably lead to better coordination and communication across different players. And we know that health is a complex subject, and we don't have to demonize or idolize one set of people or organization or sector. How do we all come together? The epidemic has shown that it is a complex way. I mean, no governments or an institution in isolation can manage. It does require multiple players, and therefore there is need for greater communication and coordination among different players. The third, thing that I thought of was investing in our health care workers and health providers intensely, not only looking at them as as employees, but as individuals who have their needs, and they are the ones at the cutting edge, investing in their well-being, in their skill building, and in their ensuring that they're able to manage their personal and professional lives well. Dr. Murthy talked of some redesigning, especially in terms of having a public health cadre, which is so critical in times like this. But I would argue even in normal times, it is so important to have a public health cadre that can manage the public health functions. And we talked of the distributed care. I think one thing to me that again stood out as I converse more and more, and as last 1 year has made us believe even more about the power of distributed care. Mr. Wajid, I was surprised, also spoke of that the standalone hospitals were extremely helpful. Dr. Evita talked of standalone small maternity units. And so having a strong primary health care, which is, and more distributed care would be, it is always easier for everyone to access care which is closer. It is easier to build trust when there are smaller and you are more integrated with the communities rather than being very far off and very isolated from what is happening around you. And finally, I think the health system, it's not only a question of health systems, it is also the more empathetic systems in general, whether it is education that Dr. Murthy talked of. In this case, I was reminded of how transport played a huge role. Absence of transport made people really, fend for themselves when they felt ill or diseased. So thank you once again. This was an extremely, extremely illuminating and insightful discussion, and taking back a lot from me. And I would leave the summary of this as well as the previous session to Dr. in the able hands of Dr. G. Chandrasekhar, and back to Arnaz to take that ahead. Thank you so much. Bye-bye.
Thank you, everybody, for this enlightening panel discussion. Lots of knowledge nuggets there for all of us. Thank you so much. I would now like to invite Dr. G. Chandrasekhar, who is the Vice Chair at LV Prasad Eye Institute, to give the vote of thanks and kind of summarize the morning for us. Over to you, Dr. GC.
Thank you, Arnaz. Thanks, everyone. At the outset, I would probably first thank the team of DVR, Arnaz and Prakash, for having put together this kind of a illuminating two-session EHAC virtual meeting, both on the 5th as well as today. I think what transpired and what we discussed was very illuminating, very soul-searching, and very educative. A lot of things to be thought through as to what we do in future. The talks in the first session, I don't have to talk about it again probably, but the perspective that Sailesh brought from the climate healers, I think was phenomenal. I think that was something that totally unexpected, beyond anybody's thought process as to what was going on and opened our eyes to a great deal. Special thanks to the ISB team, Astha, Meenal Agarwal, and Girish, and ISB Max Institute for Healthcare from North, Soumya Shashidhara, for her help in putting all this together. I think we are greatly indebted to ISB for this. With those special thanks to the organizers, I think the next set of thanks are due for all the panelists and speakers for sparing their time, knowledge, and talent. I think it has been very educative. I'm sure they learned a lot and everybody learned a lot. If I know that DVR multiple times said that a monogram is going to come with all the discussions and things like that, but I'll still venture putting some summary on what all transpired from the morning. I think it was great to listen to Subodha, who wears two hats of the business, marketing, supply chain management, bringing those insights into the healthcare. And he very nicely talked about the opportunities and the growth that is possible with the pandemic learnings that we have had. I don't know much about these things, the blockchain, the transparency that it would bring, and the decentralization of the data, and in the cold chain management and things like that. He also talked about how the healthcare itself can improve with virtual reality, chatbots, and telemedicine. He brought in very nicely the experiences both from the US as well as in India of various studies that are ongoing and what all we can learn from them. We look forward to the final learnings and publications from that. The insights that the panelists brought in the first session, both from primary care, critical care, and into what was the learning and opportunities in healthcare as a whole. I think the first session was very positive as to what all we can learn. And the second session was predominantly about what all mistakes we did and how do we move forward with those learnings. One thing that came out uniformly throughout in the first session was the use of telemedicine and technology that can help reduce the number of visits to the hospital and take care closer to the doorstep of the patients. And Dilip very nicely said that everybody said that technology is not a problem. Technology can find all the solutions. But I think in the context of what he said about combining the hardware and software very nicely, one of the statements that Dilip made is that we should, let me find out where I put that down. I don't want to quote him wrong. Artificial intelligence to augmented human intelligence is what he said. And Dr. Rao keeps talking about it's not just the technology and telehealth, but we need to bring in some element of tenderness in the care. And Dilip also talked about the communication gaps that might be there. And we talked extensively about the informed consent also in that context. One of the thoughts that occurred to me in that area is that informed consent is about making decisions along with the patient as what is best for them, rather than taking permission to do whatever we want to do on the patients. I think that is something that came out in the discussions in the morning. The other thing that came out in the discussions in the morning is that how can we take advanced care to the periphery? I think the model that Dilip has been working on, I think, is tremendous in that aspect. There is also one of the lessons that we did not discuss, but it occurs is from the hepatitis C care, the New Mexico University experiment on ECO, extended community health outcomes, as to how they have been using the Zoom platform for a long time, having consultations at the tertiary center for people being in primary care. Everybody brings their cases and everybody learns as to what needs to be done next when a similar case like that is there. I think another opportunity in that kind of a thing. The experience from LV Prasad Institute of having a fixed infrastructure in the rural areas and using the technology and the human resources together to be able to take the care to the doorstep, I think is one lesson, one point that came up very vividly. While we talk about telemedicine, I think the combining of hardware and software essentially means that whatever data points that need to be collected from the healthcare point of view, how do we have that hardware there and how do we gather that information so that the teleconsultation can be more complete rather than just a verbal communication between the doctor and the physician. And that Rajesh pointed out that in the neurology and other areas, that information is very crucial. Rahul talked about the challenges in the primary care with the technology that they have. I think there are a lot of lessons from there. And like Pavitra pointed out, how do we take primary care and make it more robust so that more and more of advanced tertiary care or specialty care can be delivered at the doorstep is some lesson that we need to learn. One of the other things that I remember from what Dilip said is solve natural stupidity before bringing in artificial intelligence. Training human resources, I think, is very important from that point of view. Pavitra has very nicely summarized also what happened in the second, the insights that came from GVS, Murthy, Anas and Evita was very, very powerful. I think the number of messages that we got on the chat box shows that how powerful those experiences and those insights were. I think from one of the things that probably needs once the monogram comes is that we are all wishfully thinking that we will be able to work better with the government. The evidence base and the scientific knowledge will take over the political and the political interests. That may be probably wishful thinking, but what we need to do probably is to advance advocacy with the knowledge that we gather from this. And how do we actually advocate and make sure that these things that we are talking about here actually happen in the real world is, I think, is the most important thing. And I think, I'm sure DVR would have a lot of things up his sleeve as far as that is concerned. And the leadership of people in the panel, along with Dr. Rao and people like that, I think is going to be very useful in bringing in that advocacy so that next time there is a pandemic, if we don't listen to what Sailesh told us, the next pandemic is not very far off. So we need to be better prepared for that. Cost-effective healthcare is the final comment that Evita made, and community participation and society education in times of crisis is the point that Anas made, Wajid made, and the advocacy is the point that Murthy made. So with those thoughts, I think we've had a wonderful program. Thanks to Arnaz once again and DVR and Prakash for putting this together. With that, I will close. Thanks, Arnaz.
Thank you, everybody. Thank you so much for being here. And see you next year. Thank you.
Thank you.
Thank you.
Thank you very much. Thank you.
Thank you very much. Thanks, Pavitra.
Thanks.
Thanks, JC.
Thank you.
Thank you very much, everybody.
I see you all.
Bye.
Thank you.
Bye.
Thank you.